Hello, hello. Today we are very, very pleased to have a chat with Professor Sharon Einav from Jerusalem, who is a very active professional in our field, and I would say a very dynamic and knowledgeable woman in intensive care. So we are really very pleased to be with you, Sharon. Hello, hello.
Thank you. It's a pleasure and an honor to be here.
Perhaps I can start with the common question nowadays. How is the situation with respect to COVID in Israel and in Jerusalem in particular? Do you have many patients in the ICU?
Yes, mainly ECMO and post-COVID patients, quite a few. The majority of ICU patients, in fact, are at the moment COVID.
And yet we spoke so much about vaccination in Israel, and you started so well. It's a bit, it surprised us to see the number of COVID cases that came later.
Yes, I think that as long as there is a certain number of people in the population that don't get vaccinated, then we're going to continue seeing this probably for a good while.
Do you have any new therapeutic interventions, something that you would like to do or to study in these COVID patients?
Well, I would be a millionaire if I had, I think.
Well, maybe it would be too late. By the time you study it, the pandemic may be over.
Probably.
No, but right now you don't say we have something special in Israel. We give a vitamin cocktail or ivermectin because we believe in ivermectin. No, nothing miraculous.
I think it would be unprofessional of me if I said there is anything that we can actually prove that it works. At this moment, I think the best thing is prevention. And, everybody comes out with their brilliant ideas, but I have to say I'm a bit of a cynic.
Corticosteroids, I suppose, and anti-IL-6 as well, no?
I am also skeptic about steroids. There is a whole argument. There's a discussion about this. We could talk about this for all the time that we have left, but and I'm quite aware of the meta-analysis and the data that's out there and the studies. I'm still not convinced that the data is sufficient for critically ill patients, and definitely not in the balance when we look at infection as well.
That's interesting. So, we will shift gears a little bit and speak about sepsis in general, but I would like to know your thoughts about protocolized care versus individualized care for COVID. We need to be more or less protocolized, aren't we? But don't speak about COVID anymore. In sepsis in general, protocolized versus individualized care. Tell me.
So I may be a bit old school in this, but I honestly believe that there is a lot of place for the individual doctor's way of doing things. And while protocols are a pretty good beginning point, it's exactly that. It's the beginning point. And from this point on, we need to consider for our individual patient what is right and what is not. My main issue with protocols is that it becomes benchmark for quality. And it's not necessarily a benchmark for quality because it's not a one size fits all, a concept in medicine at all.
Very good. I cannot agree with you more. But, we are happy to have the Surviving Sepsis Campaign guidelines, of course, but they have their limitations. Could you perhaps outline some of these limitations in your opinion?
So I just like first to say that I very much respect the work that has been done. I mean, it's a huge, massive work, and please don't take this anywhere negative. But I think that the main problem that underlines many of these guidelines is the quality of the data. And the way I see it is you can sit a group of people that are like-minded in the room and make decisions and come out with best practice statements, or even strong recommendations based on a little bit of data, because that is what these people believe in. But ideally, I think it should be, if we're coming out with recommendations, the best way to do it is really to base what there is on data, and what there isn't to say there isn't enough data, please go out there and do the the research, because it's a bit like, you know, putting the dirt under the rug, because you write these beautiful recommendations. People don't bother reading what's in the little text underneath, and no more research. And that's a tragedy for me.
Yeah, absolutely. Now, as you allude to, the difficulty is to conduct prospective randomized control trials that could really improve the field. And we always target mortality in heterogeneous patient populations with negative results, and it's difficult to make recommendations out of these data. Do you think mortality is a good endpoint in these heterogeneous groups of patients?
I think that a heterogeneity is not a good starting point. I agree with you entirely. And mortality is tricky. I think that if a patient doesn't die, that doesn't mean they come out well. And we're seeing this in COVID. We are seeing this in sepsis. And I think we need to start being a little bit more nuanced with the outcomes that we are seeking. It's true that it's difficult. It's more, you know, maybe not as black and white as life and death. But in resuscitation studies, for example, outcomes have moved from live or dead to something more sophisticated. And I think we should be doing that with sepsis trials as well.
I agree. Yeah, absolutely. If I could ask you, what is the best randomized control trials in sepsis that you have seen? Can you cite one or two?
I can definitely cite one. Despite the fact that you are the person interviewing me, I'm going to say that, in my opinion, probably the best trial that I can think of in relation to sepsis is the trial that Daniel De Becker published in the New England Journal in, it was 2010. And mainly because this trial had...
on dopamine versus norepinephrine, huh?
Exactly, on dopamine versus norepinephrine. First of all, it actually changed practice. It changed the guidelines, it changed practice. And it taught us, I think, more than anything, and this is a classic example of why mortality is not always the only important outcome, that when we are looking for one thing, we should not forget to look in other directions as well, because maybe there may be hidden signals. So for me, this is a beautiful study. It was well conducted. It had a large sample size, an appropriate sample size. It's sad that this was actually the largest and the strongest study on vasopressors conducted since then. There have been publications in the New England on other studies, but probably not as good as this one.
Thank you. Yeah, I of course appreciate that. But can you go to the other extreme? We don't want to be too negative today, but what is the study that you find the most useless, if not most stupid one? I have some ideas about this, but you are interviewed.
Okay, so I'm going to be a little bit mean. I have a whole list, but in order to not give a list, and I also don't want to insult anybody, I would say this: any study should begin by looking at a meaningful endpoint, by looking at something that has no clinical impact. We are past that point. I think we need to forget that and to move to clinical outcomes. And any study that for me has no clinical outcome is only, it raises more questions than answers. It's not enough.
Okay. Any wish for the future, something you would like to study, and if you had the money and the people going with you, what would you like to study?
I think we need more data on, I would say two topics. One, I think definitely more on vasopressors in septic shock to me, and that is it's still a big hole. And anybody
of vasopressor or the blood pressure level or both?
Probably both. Both. And we know that, for example, the last guidelines discussed the blood pressure of 65, blood pressure of 65. And we know that it's arguable. And yes, again, it's a good starting point, but let's move on from there. I would also love, and this I would really love, to get more information about pregnant women that are critically ill. I know it's a bit off the beaten track. to me, it's stunning that there still need to be publications proving that pregnant women that are critically ill do better in the ICU, and there have been this year. And so I don't know. I think this is again another place that is still, we need more data.
Okay. Very good. And that will bring my last question. What can we do to promote women in intensive care? You are a leader. Tell us.
Oh, okay. Women.
Briefly.
Quickly. First of all, let's make less noise about this. I'm against quotas. I think quotas are not a healthy way to move forward. I'm for merit. I don't think that women need to be in every single paper because you need a woman to be on every single paper. I do think women need mentors that are not afraid to mentor women. It's a challenge. I will say I've been mentoring women. It's different sometimes. And women are not men. We cannot argue that women and men are different. Sometimes we need to look at different approaches to things. To me, mentoring is number one and giving opportunities is number two. But definitely not to me, quotas. For me, that's a big no. And I know I will be unpopular for saying this here. I'm sorry.
No, I think it makes sense. I think our time is already over, but I would have loved to continue this discussion for a long time with you, but we will certainly repeat it during each chat or at other occasions. Thank you very much, Sharon. Thank you, and take care. Bye-bye.
Bye-bye.